It's my pleasure to introduce Domenica Lorusso. She's from the National Institute of Tumori in Milan, and she will talk about niraparib.
Good afternoon. Thank you for inviting me. So, as Isabel reported, up to 50% of high-grade ovarian tumor present an impairment of HRD recombination system. And PARP inhibitor has the potential to be extremely active in such population because they directly inhibit PARP, but also they trap it on DNA. Niraparib is a selective PARP1/2 inhibitor which has demonstrated in preclinical trial to be very active in patient-derived tumor xenograft model, both in tumor with BRCA mutation, but also in tumor without BRCA mutation. NOVA trial is a randomized trial comparing niraparib versus placebo as maintenance treatment in patients with platinum-sensitive and platinum-responder recurrent ovarian cancer. What is very interesting from my point of view are the pharmacokinetics and pharmacodynamic properties of this drug. The high oral bioavailability, which is not related to the assumption or not of fat, the extensive tissue distribution, the liver metabolism, which is independent by cytochrome P450, and finally, the very long terminal half-life of about 2 days. Phase 1 trial reported MTD at the dose of 300 milligrams per day being hematological toxicity, the dose-limiting toxicity, particularly in terms of anemia and thrombocytopenia. Phase 1 trial reported up to 75% of response rate in BRCA-mutated platinum-sensitive patients, but also an interesting 60% response rate if patients were resistant with BRCA mutation. Very interesting from my point of view is that progression-free survival, median progression-free survival, was quite the same regardless if patient bearing or not BRCA mutation. And also, up to 11 months progression-free survival was reported in platinum-resistant patients with BRCA mutation. NOVA trial was a randomized phase 3 trial comparing the efficacy and safety of niraparib versus placebo as maintenance treatment in patients with platinum-sensitive recurrent ovarian cancer. The hypothesis of the study is that niraparib would provide a clinical benefit to all patients, regardless BRCA mutation. Patients with high-grade ovarian cancer receiving 4 to 6 cycles of platinum-based chemo, if respond to chemo, were randomized no more than 8 weeks after the completion of treatment in a 2-to-1 ratio to receive niraparib or placebo. 2 parallel cohorts of patients were enrolled: the gBRCA mutated patient and the no gBRCA mutated patient, selected according to the criteria of repeated platinum sensitivity. Before data lock, the non-gBRCA mutated tumor tissue were analyzed according to the HRD test that Isabel explained, which is a very interesting test able to identify patients with the so-called HRD signature. All these tests were centralized. There was a very great balance of demographic and clinical patient characteristics in the 2 cohorts. And what I want to point out is that half of patients in the gBRCA mutated cohort and a third of patients in the non-gBRCA mutated cohort had previously received at least 3 chemotherapy lines. So we are talking about a very heavily pretreated population. Also, patients well balanced according to all the stratification factors, and in particular, 40% of patients presented what we call the intermediate sensitivity. 50% of them reported a complete response to the last platinum treatment, and about 25% of them had previously received bevacizumab. The primary endpoint of the trial was progression-free survival in the 3 efficacy populations. The first population was the population of BRCA-mutated patients. Niraparib significantly increased progression-free survival. Median progression-free survival increased from 5.5 to 21 months with an hazard ratio of 0.27. In the no-gBRCA population, niraparib increased median PFS from 3.9 to 9.3 months with an hazard ratio of 0.45. In the no-gBRCA mutated cohort with HRD positive signature at test, niraparib increases progression-free survival from 3.8 to 12.9 months with an hazard ratio of 0.38. What I'd like to underline with you is the shape of these curves. These curves are not what we call banana curves. This curve does not meet, does not cross. They are separated curves, thus suggesting a long-term benefit for our patient. In order to understand if it was the somatic BRCA mutation to derive this benefit in the HRD-positive patient, the HRD-positive patients were analyzed in a pre-planned exploratory analysis according to the somatic or not BRCA mutation. As you can see, in both groups, somatic BRCA mutated patient, but also somatic wild-type BRCA patient, niraparib gave benefit in terms of increasing of progression-free survival. And I just want to point out that in somatic BRCA mutated patient group, the magnitude of benefit is 0.27, very similar to what we obtained in the germline mutated cohort. But what is more interesting for me is that we also saw benefit in the HRD negative population. And actually, 20% of patients derive a benefit, a long-term benefit, more than 18 months after randomization, thus suggesting that the HRD signature is not enough sensitive in identified patients who may derive benefit from niraparib. Forest plot analysis suggests a benefit, the consistency of the benefit of niraparib in all patient population, regardless if they were partially sensitive or fully sensitive, if they have received or not BEV, whatever was the response to the last platinum treatment, whatever was the number of previous chemotherapy line, and for sure, whatever was the BRCA or HRD status. A lot of secondary endpoints were analyzed in the trial. All these endpoints are surrogate endpoints of survival. In both cohorts, niraparib increases chemotherapy-free interval in a very significant way. But also, niraparib significantly improved time to first subsequent treatment in both cohorts. And finally, although data are immature, there is a preliminary, very significant effect of niraparib in increasing progression-free survival too, which is the time interval between niraparib administration and the subsequent progression during the subsequent treatment. What about toxicity? As phase 1 studies suggest, hematologic toxicity is the dose toxicity of this drug. So, in 34% of patients, grade 3-4 thrombocytopenia was reported. Grade 3-4 anemia was reported in 25% of patients, and grade 3-4 neutropenia was reported in up to 20% of patients. No difference in terms of myelodysplastic syndrome was reported between patients receiving niraparib or placebo. Hematologic toxicity is very typical with this drug. It appears typically in the first 3 cycles, and in particular, thrombocytopenia appears in the first 3 cycles, and beyond the 3rd cycle, platelets return in the normal range. The trial had very strict rules for dose reduction and dose interruption. Thrombocytopenia was the cause of dose reduction in 40% of patients, but as you can see, only 3% of patients discontinued treatment because of toxicity. And what is more important for me, because we are talking about maintenance treatment, quality of life of patients was not impaired by niraparib. And Jalil will explain. So in conclusion, niraparib is a very potent PARP1/2 inhibitor with a favorable pharmacokinetic characteristics. Niraparib in NOVA trial significantly improved PFS in patients with platinum-responsive, platinum-sensitive recurrent ovarian cancer, regardless BRCA mutation of HRD status. Hematological toxicity, particularly in terms of anemia and thrombocytopenia, appear manageable with a low percentage of patients discontinuing treatment without impact on overall quality of life. And finally, the clinical development of this drug still continues. The AVANOVA trial is recruiting and will test the combination of niraparib with Bev in the 2nd-line ovarian cancer treatment. PRIMA trial will test niraparib as maintenance in the 1st-line ovarian cancer treatment. And the BRAVO and TOPAZIO trial will test the activity of niraparib as a single agent in breast cancer and ovarian cancer. Thank you so much.
So, thank you very much, Keta. Let's take the discussion now for the 2 talks. Questions?
I have a question for Keta.
Yes, Isabel.
2 questions, in fact. First, I'm a little bit surprised. Finally, few patients received Bev before. We discussed about this compound as a standard of care, and only 26% of the patients received Bev before.
Yeah, the reason is that almost half of the patients were from US and Canada, and Bev is not labeled there. Yeah. So that is one of the reasons.
This is the explanation.
Yeah.
And the second point, probably a statistical point. When we look at the odds ratio in all the HRD positive, including BRCA, the odds ratio is 0.38, sorry. 38. When we remove the BRCA mutated, and we know that S BRCA is exactly the same than G BRCA, we keep the same odds ratio.
But you can see the confidence interval becomes broader. Sorry, Keta.
It was the same answer.
It's just because of
the number of patients become smaller, and that means that confidence intervals become broader.
Now, the question is, the critical point of this study from a point of view is the test, the HRD test, which is your point during your discussion, because for sure, in an ideal world, we'll desire a test able to identify patients who will or not will receive niraparib, but I would say whichever drug. But even if in HRD negative population, the other ratio is less impressive, for sure that in GBRCA, it is very difficult from a point of view in this moment to say a patient, I can't give you a drug, even if 20% of patients may derive a long-term benefit from niraparib. So the test, from a point of view in this moment, is not enough sensitive to identify patient population who will receive it. Probably it should be ameliorated, but in this moment, I think that the old but still working criteria of platinum sensitivity is much better in identify patients who may respond to PARP inhibitors, and niraparib in particular.
And can I add to that? I think I completely agree what Kate is saying. The separation because of this HRD test is a hazard ratio moving from 0.38 to 0.58. This tells us that HRD positive population is having a better benefit, but it doesn't tell us that HRD negative population is not benefiting. It is not telling us that we should not treat HRD negative population. To be very rude, I would say if we could approve bevacizumab in OCEAN trial without any quality of life, with the same benefit or less, because that is a banana curve, there's falling apart. Here, you, as Keta said, 19% of the patients are on treatment without benefit. It's difficult for me to tell a patient, look, you have 42% chance, and 1/5 of the patients are long-term responders, and there won't be any detrimental effect on quality of life, but I'm not going to give you the drug. That's going to be difficult. So we really need to work hard on finding out why HRD test is not working. Because if you look at the data, their validation of my choice, which is done on the data which was from TCGA, the HRD panel, it's perfect. So probably that's not the true story. There are other mutations, there are other way of mechanism which we don't have, which has to be added in such a test. So we need a better test.
Probably the challenge for the future is that all these tests are validated on TGCA, but TGCA is our patient in new diagnosis, the first line.
Yes.
And we all know that the tumor will change at recurrence, so we need tests that possibly will be validated in the same patient population we want to use it.
And remember that the test was explore on platinum sensitivity and none on PARP efficacy.
Exactly.
Yeah.
And it's something that we make a parallel, and it's right, it's good, we know, but it's not exactly the same.
Yeah.
So we do know that BRCA mute patients have the highest chance. HRD positive has a little bit less. But that doesn't mean that HRD negative are not responding. They are responding, and you cannot tell them that you are not going to treat them.
And even the platinum-resistant patients sometimes respond.
Yes, but we haven't got the level 1 evidence yet,
course,
unfortunately. But probably now we would be able to do the trials in that population.
Yeah.
Good. More questions? Yes. As Keta, would you like to?
Yes. We have a trial ongoing, which is a single-arm phase 2 trial addressing the role of niraparib as a single agent in breast cancer. And possibly a registrative trial, but for sure it depends from the results.
Maybe I'm gynae oncologist and I'm biased, but I believe that platinum sensitivity is probably more important, and I'm not sure all the trials which are going on in breast cancer, what would be the outcome. That's my bias.